Welcome to Chapter 40, Respiratory Dysfunction. Respiratory problems can result from structural problems, functional problems, or a combination of both. Structural problems, such as alterations in the size and shape of the parts of the respiratory system. Functional problems will be those associated with gas exchange, infections, or irritants in the lungs or respiratory tract. Alterations with the immune system and the neurological system also affect the respiratory system. A child's respiratory tract grows constantly until they are age 12. You should also know that a child's neck is shorter than an adult, which results in airway structures that are closer together. Because their little airways are so narrow, the effects of airway edema are much more pronounced in children. Increased respiratory secretions are also a bigger deal for kids too. Because their airways are shorter, it is easier for pathogens to move downward, involving more of the structures. Oxygen consumption is higher in children than adults because of their greater metabolic rate. Children also have fewer glycogen reserves, which means faster muscle fatigue when accessory muscles are used for breathing. I have a note in your transcript and a note in my slides to show you guys or tell you guys about a regular straw and a big straw. And what I was trying to illustrate with that is just to think about the airway of a baby is about the width of it's like about the width of a really like a normal size straw. So if you think about it, it does not take much airway edema at all when your airway is already so narrow for the airway edema to actually become a pretty significant problem. And that's pretty much what the illustration on your slide is trying to show you as well. So on this slide, I just want to really draw your attention and point out bronchioles in children are much more narrow, and there's fewer of them than adults have, even though their whole tracheobronchial tree is complete. We talked about this with babies already. I know I stress it, and I'm pretty sure that Dr. Wheeler talked about it too. Neonates have alveoli by 32 weeks. So if you're talking about caring for babies who are born before 32 weeks, they're going to have crap for gas exchange because they don't have the structures necessary for gas exchange. Just saying. Full-term babies have about 25 million alveoli. Adults have 300 million. The rest of the stuff you can kind of read through here. The big thing I want you to know, it's really helpful if babies can stay well in those first few months because they just don't have the ability to fight infection effectively. Look at the actual structure of their airways. It's crap. So I want you guys to know that bacterial and viral respiratory infections, they can be located in either the upper or the lower respiratory tract. Infections are a little bit more rare in children who are less than 3 months of age due to the maternal antibodies that mom sent over at the end of the pregnancy. However, from 3 to 6 months of age, there's an increased risk of infections because some of those antibodies the immunity is starting to wear a little bit thin. And then interestingly enough, there's a higher incidence of acquiring pertussis during that time too. So that is always going to be a concern, especially for those parents who are anti-vaxxers, because pertussis, unfortunately, is rearing its ugly head in our society, in our culture again. All right, so clinical manifestations of respiratory infections in kids. I think you guys have probably got this down, but I just referenced a box on page 1196 for you to look at. As far as the care management goes, to ease the respiratory efforts, warm or cool mist vaporizers work really well. Moisture helps soothe the inflamed membranes, and it's helpful for any kind of hoarseness or, loss of voice. 10 to 15 minutes in a steamy bathroom will do wonders for a kid who has a stopped up nose. Cool mist is recommended for home use due to the risk of burn injury associated with hot vaporizers. So that's something to do, something to know, a good teaching point. It's important to promote rest, promote comfort, make sure parents know how to use the bulb syringe. And this is even for kids who are, up to 2 years old. It's important for you to show them how to clean out their nose. Saline drops are going to be your best friend because you're probably not going to be able to suck out much of anything without it. But it's amazing if you just put a couple drops of saline up their nose, let it set, you'll suction out, large wads of snot. It's super thrilling for nurses. Because let's face it, we love sucking snot, we love popping zits, we love doing things like that because we're nurses. Um, Nasal decongestants really aren't recommended for little kids anymore. There are some kind of homeopathic type remedies that you can find out there. And sometimes pediatricians will go ahead and recommend a few on an adjusted small pediatric dose if need be. It's very important if you're caring for a child, please teach the parents to please keep sick kids out of daycare, school, and try and prevent the spread of the respiratory infection. Yeah, good luck with that because it's like once one kid gets it, it introduces it in a class, it's gonna work its way around. So, what can you do as the nurse? Promote hand washing, show people how you wash your hands all the time. That's kind of about all. Make sure you don't touch your face either. When you're taking care of children, if you need to rub your eye, you rub your nose, always go wash your hands first because that is one of the number one ways that I have found and seen that people get sick, especially from cold things. Things you can do to reduce fever: Tylenol and Motrin. You can also do cool fluids, have them, have suck on popsicles, things like that. Promote hydration. We're going to avoid caffeinated drinks. Duh. Popsicles, kids love popsicles. Popsicles are a great source of hydration for kids. And pretty much whatever the child is willing to drink. And then, of course, provide adequate nutrition. Nasopharyngitis, or the common cold, upper respiratory infection, usually is caused by things like rhinovirus, adenovirus, enterovirus, influenza, parainfluenza, group A strep, or RSV. All right, strep throat. Very common. Children get this all the time. So in children who get strep throat are at higher risk for developing rheumatic fever, which causes inflammation of the heart, joints, and central nervous system. And it can also cause acute glomerulonephritis, which is an acute kidney infection. Permanent damage can result from those two acute conditions. So it's kind of a big deal. Clinical manifestations of strep usually subside within 3 to 5 days. It is possible for people to be carriers of group B strep and yet not have, quote, strep throat. Strep throat, of course, is going to be diagnosed with a rapid strep or throat culture. It's treated with 10 days of penicillin. Now, children can get a shot of penicillin, and sometimes parents will request that. The shot will make them feel better faster, but it is preferred actually to give kids 10 days of oral penicillin. And the reason is if you give a kid a shot, it immediately bumps them up to that therapeutic range of penicillin, but they fall out of that therapeutic range faster. But if you give a child 10 days of oral penicillin, it takes them a little bit longer, takes a couple of doses on board, but then you hit that therapeutic range of penicillin, but you stay on the oral medicine for 10 days, and so they actually end up staying in the therapeutic range longer. So, as crazy as it sounds, PO or oral penicillin does a better job at eradicating a strep infection than a strep shot or than a penicillin shot will do. Crazy, huh? And the other thing that we can do is, as far as comfort care, we all know, gargle salt water. Why is it that nurses always want you to gargle warm things? What does warm do? Let's think about it. If we had somebody gargle warm salt water or drink warm fluids when they're sick, what does warmth do? It promotes blood flow. So it's going to promote edema. It's going to promote inflammation. Inflammation and edema also kind of encourages pain. So are we going to really make anything better by sipping warm or hot fluids? No, we need cold stuff. So if someone is going to gargle cold salt water, that's a whole lot better than warm. Slushes, cold drinks, because what does cold do? Cold helps reduce inflammation, which reduces pain, which reduces blood flow, which is going to reduce edema, which is going to reduce all those things. It's going to reduce that swelling. It's going to help you feel better faster, honestly. You can also give Tylenol or Motrin for comfort as well. So tonsillitis frequently occurs with pharyngitis. When inflamed, you should know that tonsils can grow so big that they actually meet in the midline of the mouth. Those are called kissing tonsils. If this happens, it can be hard for the child to swallow or even breathe. Tonsillectomies are usually indicated for 3 or more strep infections per year, a persistent foul taste or breath, or nasty like strep breath, which is caused by tonsillitis, chronic unilateral tonsillar hypertrophy, malignancy, or chronic tonsillitis in a strep carrier who fails to respond to antibiotics. Whew, that's a mouthful. Um, tonsillectomy. Okay, so post-op, let's talk about that because this is NCLEX material right here. Post-op, soft food, no citrus juices. Why no citrus juices? Because they burn, right? Orange juice is not a good choice. No citrus juices. They're at risk for dehydration because it hurts to swallow. So if something hurts, do you want to do it? No. You can kind of reason with adults to get through pain. Kind of. And I say that because you know how I feel about adult patients. But it's really hard to reason with kids sometimes. If it hurts, they just don't want to do it. They're smart. So dehydration is definitely a concern. Ear pain, common 4 to 8 days post-op. Why is that? Ear pain is because they feel those scabs because they feel that healing, and it's so close where, the location in the back of their throat, the sensation is actually picked up by the ear. Tylenol, Motrin, sometimes kids will have opioids for pain control too. This is a thing. Teach parents about post-op hemorrhage. Kids don't stay in the hospital very long anymore, right? We do everything outpatient. We get them in, get them out. That's good, and that's kind of bad too. So post-op hemorrhage can occur up to 14 days after surgery. 2 weeks later, kids can still hemorrhage from a tonsillectomy. Thankfully, this only occurs in about 5% of patients. Obviously, there's going to be blood, but what else are you going to be looking for? If you're bleeding out, what's going to happen to your heart rate? It's going to go up. You're right. You're going to have tachycardia. If you're bleeding out, are you going to be nice and rosy and pink? No, you're probably going to look kind of pale and have some pallor. What would be another ominous sign? When kids start frequently clearing their throat. Think about when you guys are getting sick and you have all that drainage and all that nasty stuff, just like postnasal drip, just dripping down your throat all the time, and you're all the time. Yes, that is an ominous sign that there is bleeding or hemorrhaging in a kid if they start doing that a lot. And then obviously the stomach does not like to digest blood. Blood doesn't usually set well with the whole stomach. Usually it will reject it, and kids vomit and they puke the blood right back up. So those would be signs and symptoms of post-op hemorrhage. And that is very important to teach your parents. That is the kind of crap that NCLEX is made up of, folks, right there. So influenza. Whew. Do we not know enough about influenza already, folks, right? H1N1 or swine flu, pig flu, is a subtype of influenza A. It has a 1 to 3 day incubation period. Influenza, just in general, has an affinity for the respiratory tract mucosa where it destroys the ciliated epithelial cells with metaplastic hyperplasia of the tracheal and bronchial epithelium. Woo, that's a mouthful, right? So basically, to sum that up and kind of put that into simpler terms, it destroys your ciliated epithelial cells, and it's going to screw up your epithelium in your bronchial tree, basically. Alveoli also become distended with a hyaline-like material, so your lungs fill up with crud and junk. Symptoms of influenza usually last 4 to 5 days. I'd like to meet someone who got through the flu in 4 to 5 days because most people I know are sick for at least a solid week or longer. Complications of influenza do include viral pneumonia, encephalitis, secondary infections such as ear infections, sinusitis, or bacterial pneumonia. Tamiflu, this crazy expensive drug, only works for type A and B influenza. pretty sure that Tamiflu is made up of unicorn tears because if you go to buy it, it's crazy expensive. Not as expensive as Synagis for RSV, but it is still kind of crazy expensive. Flu shots. Everybody has an opinion about flu shots. Unfortunately, if you're going to work in healthcare, you really kind of don't have much of an option or a choice. So even if you're against flu shots, you pretty much have to take it anyway, or you're pretty much not going to have a job. So, but for other parents who come in, I've talked to many parents who are very much against flu shots, and I've talked to many parents who are very much pro flu shot. So, um, it doesn't really matter for you guys. Flu shots, you know, the flu shot is really just somebody's best guess about what flu they think will hit the area where you live, or they think is going to be the predominant type of flu. And it's just an educated guess. So it's kind of like predicting weather. Maybe it'll come, maybe the rain won't come. Who knows? All right, otitis media, ear infections. In little pediatric throats, the short open eustachian tubes allow pathogens very easy access to the middle ear for ear infections. Children have a higher incidence of ear infections in the winter months. Why? Well, because it's usually preceded by a respiratory infection such as RSV and influenza. It can also be caused from bacterial things like strep pneumonia, Haemophilus influenza, or the Moraxella catarrhalis. You should also know that boys tend to get more ear infections than girls. Ear infections tend to run in families. Children of smokers have a higher incidence of this because the smoking paralyzes the cilia that are supposed to clear and clean the respiratory tract. Okay, so even though the children themselves are not smoking, which let's hope and pray they are not, even just being subjected to the secondhand smoke still paralyzes the cilia in their lungs that are supposed to clear and clean out the respiratory tract. Other predisposing factors include upper respiratory infections, allergies, Down syndrome, cleft palate, daycare attendees, and children of bottle proppers. Yep, people who just lay the baby down in the boppy and prop the bottle and then go on and do whatever it is they're going to do. Breastfeeding is actually protective against ear infections because the breast milk contains antibodies which limit the exposure of the eustachian tubes to pathogens. In this picture, you can see the air bubbles that are behind the eardrum. So that's a middle ear effusion. Eustachian tubes are supposed to protect the middle ear from nasopharyngeal secretions, drain secretions from the middle ear to the nasopharynx, and ventilate the middle ear to equalize pressure from inside the ear to the outside world. When the eustachian tubes get plugged up or get infected, then they don't do those things. Antibiotics that can be used. Amoxicillin is sort of the go-to. It's the first choice. Then pediatricians usually lean towards Omnicef, followed by Augmentin, and then azithromycin. For children who have acute otitis media, especially if they have the effusion, it is really important for these children not to be around smokers. They will need to have their hearing evaluated. If hearing loss occurs, they will need to follow up with speech therapy. Interestingly enough, antihistamines and decongestants have not been shown to be effective in treating otitis media, with or without the effusion. When the child has ear infections that persist despite antibiotic treatment, or if the ear infection lasts 4 months or longer, doctors can do a myringotomy, which is a surgical incision of the eardrum. So basically, the myringotomy is they just cut the eardrum, and then the tympanostomy tubes, aka tubes in the ears, are then placed to equalize the pressure within the ear and help facilitate the drainage of fluid. Doctors usually do both procedures if they put, quote, tubes in the ears. They do that if a child has frequent ear infections. You really can't do one without the other. And then I have a YouTube video clip on here if you guys want to watch it that just shows tubes in the ear surgery. And this will conclude part 1.